Hi, everybody. Welcome to today's Student-Led Journal Club seminar. My name is Anne-Marie Parker. I'm a research associate for the Joplin campus of KCU. Today's Journal Club seminar is going to be by student Dr. Tanner Karlinger-Gladney. Student Dr. Karlinger-Gladney is a fourth-year medical student at Kansas City University and MBA candidate through Rockhurst University. He's originally from Pueblo, Colorado. Student Dr. Karlinger-Gladney did his undergraduate work at Arizona State University, where he earned his degree in Kinesiology with a minor in human nutrition. He went on to earn a master's degree in Biomedical Sciences at KCU prior to matriculating into the College of Medicine. During his third-year clerkships, Tanner found a passion for women's health and is planning to pursue a residency in Obstetrics and Gynecology. Outside of medicine, he is an avid lover of food and loves to cook up amazing dishes with his wife while enjoying a glass or two of wine. Today, student Dr. Karlinger-Gladney will be presenting an overview of genital urinary changes associated with menopause, something he observed quite frequently during a urogynecology rotation at the University of Connecticut. So with that, the floor is yours.
Awesome. Well, thank you so much for that wonderful introduction, Anne-Marie. For those on the call who don't know me, my name is Tanner Karlinger-Gladney, and today I'm going to be presenting on the genitourinary symptoms of menopause, something that I found very interesting during my rotation in urogynecology. Something that I thought was super interesting as I began to research this topic is a lot of the pathologies that are associated with urogynecology, so a lot of pelvic organ prolapse and urinary incontinence are the primary two. I think can be tracked back to GSM. So the purpose for today is kind of twofold. So today we are going to be defining the etiology and pathogenesis of GSM and talking about the clinical manifestations that you may see patients present with. We're going to discuss anatomic and physiologic changes associated with this pathology. We'll review some current treatment recommendations that include conservative management, the lifestyle choices, and some other conservative sides of management. Our gold standard, which is hormonal-based therapy. And then we're going to do a very brief introduction of newer laser therapy treatments. The laser therapy treatments, as I learned during my rotation at UConn, is very much beyond, I think, my knowledge base right now. So I don't want to not do it any justice. So I just want to give a brief introduction to that. From there, we're going to shift gears a little bit in this overview, and our discussion is mainly going to focus on issues related to underreporting and underdiagnosing of GSM. We'll talk about problems related to the Dhea questionnaire, which is the questionnaire used in clinical diagnosis of GSM, and some potential improvements that we can make relating to diagnosis. So when we're talking about any sort of overview, it's a good thing to define what we're talking about, right? So GSM, the term, kind of an umbrella term, came about in 2014. And I think that it did a good job of encompassing a lot of these former kind of diagnoses and these former names associated with the same thing. So vulvovaginal atrophy, atrophic vaginitis, and urogenital atrophy. These are all referring to a lot of the pathology and symptomology that we see with GSM. However, I think these focused a lot more on kind of the anatomic and clinical manifestations that we see, and not necessarily addressing the overall problem, which, as you can see that I highlighted here, is a hypoestrogenic state. That's really what we're going to be focusing on throughout this presentation, because as we know, all women eventually go through menopause and reach a state of relative hypoestrogenism. So we're going to talk a little bit about why some women, up to 50% of women actually suffer from GSM and for some reason develop this pathology in that hypoestrogenic state. The GSM on kind of a global scale refers to a chronic progressive condition that affects the GU system that is related to this hypoestrogenic state. Most patients are perimenopausal or postmenopausal, so that's that 45 to about 52-year-old region, or older than that. They can be postmenopausal in this as well. The three biggest symptoms and chief complaints that any of us, OBGYN, primary care, emergency medicine can see is vaginal dryness, vulvar irritation, and pain with sex. So if your patient presents with any of these three symptoms, it's important to put GSM within your differential diagnosis. So all this talk about hypoestrogenic states, well, we need to, I think the best way to define and kind of understand this is to have an understanding of what estrogen does in the female body. So estrogen is ubiquitous throughout the female system, right? Obviously, we have a male component to that too, but estrogen is the primary sex hormone that gives a woman her phenotypically female features, so secondary sex characteristics and associated with the menstrual cycle. But estrogen plays a lot bigger role than just in sexual reproduction and in sexual maturation. Estrogen receptors are ubiquitously expressed on every tissue of the body. We have two primaries, which are E2 alpha and E2 beta. We also have three separate types of estrogen that we see. Estradiol being the kind of potent the potent side of estrogen that we think of when we think of estrogen. We have estrone, which takes over in a postmenopausal state. And then we have estriol, which is used for treatment. So in a lot of vaginal creams and a lot of other hormone replacement. So a study that I evaluated to kind of learn a little bit more about the estrogenic effects that occur within the body, we see that in a premenopausal woman, she ubiquitously expresses E2 alpha and E2 beta. And there's also, and the estrogen that is predominant in her system is estradiol, so very potent. In that postmenopausal stage, what we see is a shift. So we see very little E2 alpha, and we see primarily E2 beta, and we see estrone take over as the primary form of estrogen. Estrone is around 100 times less potent than estradiol. So even in women who maybe not necessarily are having symptoms of GSM, they still are in a relative state of hypoestrogenism in menopause due to that shift to a very less potent form of estrogen. As I kind of talked about, estrogen has a lot more effects than just in the menstrual cycle or in sexual maturation. Estrone is that primary anabolic sex hormone within the female system. So think of it kind of as your car mechanic that is keeping your car in tune and keeping it up to date, right? It is through cellular signaling, keeping tissues very healthy and keeping them homeostatic. So that involves building smooth muscle, that involves maintaining collagen within tissues, maintaining strong epithelial barriers. And really, when we start to enter this hypoestrogenic state, we're losing a lot of that. And I think the best way to think about it is that we're creating in a hypoestrogenic state an overall poorer environment within the genitourinary system. So we see decreased lubrication that's associated with that vaginal dryness seen in GSM patients. We see actually a shift in the microbiome of the vagina. So we see decreased lactobacilli, which causes an increase in pH. This can be a nidus for recurrent urinary tract infections, as well as other GU infections. And we see an overall weakening of the tissue and the pelvic floor musculature. So, that pelvic floor that's creating that sling that is really holding up a lot of those pelvic organs and giving them support starts to loosen, and it starts to break down due to not having that estrogen signal to, keep strong, keep that integrity and keep that tissue integrity. So just a little review of the female reproductive tract that we can see here. So on the left side, this is what you see in a normal premenopausal woman. So starting kind of most distal, we have the vaginal cuff. We have a nice rugae throughout the vaginal canal. We see a very nice thick myometrium, a well-perfused endometrium. We have an ovary that is producing that estrogen and keeping everything homeostatic. Just a little anatomic review. We have the fimbriae part of your fallopian tube that gives way into your infundibulum, which then gives way into the isthmus and the cornu of the uterus. On the other side of the screen here, we see what happens in kind of that hypoestrogenic state. So we see a shortening of the vaginal canal. We see that we lose some of that rugae throughout the vaginal canal. The vaginal wall becomes thin and friable and is predisposed to trauma. We see kind of a less thick myometrium and just an overall, like I said, poorer environment of the GU tract. So we kind of talked a little bit about I think the physiologic side of things. What are the anatomic changes that we're going to see? So when you evaluate a patient, we're going to see a loss of labial thickness due to decreased adipose tissue. We see an involution and kind of contraction of the labia minora, thin, dry, very friable vulvar tissue that can be exposed to trauma. We see an overall narrowing of the vaginal introitus. And then highlighted here at the bottom, specific to kind of the urogynecology side of things, where I was seeing this the most. A hypoestrogenic state can contribute to things like pelvic organ prolapse, probably the biggest thing that urogynecologists see. So that's rectocele, cystocele. You see uterine prolapse, and really, although this is the chief complaint, I think that a lot of these cases of prolapse can be related back to the fact that these women just are going through menopause and not having that kind of, there's no gas in the car to really maintain that tissue and keep everything nice and taut, so they can suffer from pelvic organ prolapse. This decrease in pelvic floor musculature can or pelvic floor musculature integrity can lead to decreased bladder capacity and effects on continence. So we see a lot of women who suffer from stress urinary incontinence as well as urge urinary incontinence. So when a patient presents and maybe they have those top three chief complaints, right? Vaginal dryness, pain, dyspareunia, pain with sex, or vulvar irritation. What are we really going to look for in their chart? So we can look for a lot of these things that are clinical manifestations, right? So vaginal dryness being the number one complaint. 93% of women diagnosed with GSM, this is their primary complaint. This can be irritation during sexual encounters. This can also be irritation due to just general daily life. So a lot of women will have irritation with certain types of clothing if they sit for a prolonged period of time. A lot of women, again, do complain with pain with sex because that tissue does become kind of friable and thin. There can be incidents of postcoital bleeding as well as dysorgasmia. Pain with urination, I think a little bit less common of a symptom, but can present in patients with GSM. Loss of libido is a huge one. And I think that this is kind of a twofold problem. So we see women, because that primary sex hormone that is the drive for libido is going down naturally, we see a loss of libido just in general. But I think that this loss of libido also relates back into pain with sex and dysorgasmia. As humans, we're kind of conditioned to not do things that hurt. So I think that a lot of women, start to suffer a little bit psychologically in their sexual area of life because they're having pain and other symptoms such as bleeding anytime they try to engage in sexual practices. As I talked about, because we have that decrease in naturally occurring lactobacilli and a change in the microbiome of the vaginal canal, we can see recurrent urinary tract infections as well as other infections. And then incontinence associated less so with GSM, but I do think, but it definitely is a contributor to it, with about 28% of diagnosed GSM patients reporting incontinence issues. So when we look at this patient, right, what are we going to evaluate for them? Well, we always really, anytime that we have a pathology or a pathologic state in a patient, what are their risk factors for developing that? So nulliparous patients, any woman who uses alcohol extensively, oophorectomy is a huge one. And this is probably one that I think you will see in younger patients who are suffering from GSM. For whatever reason, they had to have an ovary or both ovaries removed at an early age. This can send them kind of into an iatrogenic menopause and can contribute to GSM symptoms. Kind of along the same lines, pelvic radiation due to any sort of pathology, cancer pathology, can affect the ovary's ability to produce estrogen, as well as endocrine imbalances. So the two probably biggest ones that you would see is PCOS and hypothyroidism. Both are primary contributors to GSM symptoms and a hypoestrogenic state. When we have patients present and either they have, kind of those chief complaints that can be associated with GSM, or they're at risk for having hypoestrogenism, we need to, as clinicians, evaluate them for signs and symptoms of that hypoestrogenic state. A lot of times, these symptoms can be related to other pathologies that need to be ruled out as well, and should be in the differential. So these are things like lichen sclerosis, lichen simplex chronicus, and malignancy. You know, vulvar tissue is skin, so we see squamous cell carcinoma, we see vulvar melanoma sometimes. So any sort of malignancy needs to be ruled out. Laboratory tests related to, you know, kind of doing hormone panels or anything like that, usually not needed. This is a clinical diagnosis. However, if you really felt the need to, in order to rule out maybe some of these other diagnoses, you could do a hormone panel to look at estrogen levels. And if you were really worried about any sort of malignancy or lichen sclerosis, you could do a culture and biopsy if necessary. So taking all of this information that I just threw at everybody very fast, what do we use? So, you know, your patient presents and has some of these symptoms, or your, you know, GSM is in your differential. Well, what can you do to kind of further that diagnosis to either rule it in or rule it out? The biggest thing that we have right now is the DIVA questionnaire, or the day-to-day impact of vaginal aging. So the purpose of this questionnaire is to assess the impact of vulvar and vaginal irritation symptoms on day-to-day life. This questionnaire is shown to have very good internal consistency, meaning that questions that are asking something similar are similarly answered by the cohort. It's broken up into 4 different parts, and we don't have to go through it, but I just want to give a little bit of an overview for it. So part A is dealing with kind of the daily life impact. So do you have trouble with walking, sitting, sleeping? Does clothing irritate you? Part B, focusing in on the emotional impact. So are you starting to develop depressive symptoms from this? Do you feel kind of an embarrassment from your symptoms? Are you frustrated, you know, just overall in life? Is it contributing to just a frustration that you're not happy with these symptoms? Part C, evaluating the sexual impact. So, you know, is your symptoms affecting your desire to have sex, any sort of arousal issues, or just sexual confidence? And part D, focusing on body image. So do you feel undesirable? Are these symptoms causing a little bit of a sense of loss of a part of you, and just an overall deterioration of your body? And I think what we see, you know, just the fact that there's 4 different kind of parts of this questionnaire, it is very comprehensive. It does address, I think, all the areas of life that GSM can affect. We'll talk a little bit about the problems associated with DIVA and kind of, I think, where it needs to be improved. But overall, it is a very good tool for clinicians to use in order to assess the impact that a GSM diagnosis can have on patients. So what can we do about some of these symptoms, right? I mean, this is happening in almost 50% of women go through this and are diagnosed with or have diagnosable GSM. What are some treatments that we can now offer? So conservative management and lifestyle modifications are kind of your first go-to. So this really depends on patient presentation and symptomology, right? So if they are complaining mainly of dyspareunia or vaginal dryness, you can do things like lubricants and moisturizers. Those work very well, I think, in the moment or during, you know, any sort of sexual practice. Oral vitamin D, vaginal vitamin E cream, and probiotics have mixed results. They're not very reliable, I don't think, but they are things that you can include in conservative management for patients. Something that does, I think, work very well is lidocaine compresses. So this can be used either during sex, or it can be used just on a day-to-day. As we know, lidocaine does a very good job of numbing tissue, right? This being said, I do think that it addresses the pain associated with GSM. However, I don't think that it really attacks the problem. I don't think that, you know, the answer to somebody suffering from dyspareunia is just to numb everything. I mean, the goal here is to restore their you know, sexual life to be desirable. So I don't know that lidocaine is a great answer, but it is a part of conservative management for patients looking for that conservative answer. Our gold standard currently is hormonal management. So vaginal estrogen cream at 50 micrograms of estriol potency is shown to have great results with GSM. I think it's very important. And one of the things that I experienced with patients at UConn was they're very weary of hearing that they're going to be placed on hormonal on something hormonal replacement therapy. It's very important to stress that the vaginal estrogen cream that either an OBGYN or urogynecologist prescribes for GSM is very local. There's very, very little systemic absorption. Where this comes into play is women who are either at risk or have had incidents of hormone-sensitive cancer. So, ER-positive breast cancer, endometrial cancer, some other forms that are sensitive to hormonal therapies. This doesn't really show a lot of systemic absorption. So I think that overall, it's a very little risk. The risk-benefit ratio needs to be weighed for each patient, obviously, but I think it's important to understand that it's not the same as taking systemic estrogen, estradiol by mouth or anything like that. Dhea supplementation, as well as vaginal testosterone pellets, are also a part of treatments. This mainly attacks the loss of libido and tissue atrophy, which comes as no surprise. Testosterone is, again, an anabolic hormone that builds tissue. DHEA is in that adrenal cortex cycle and can be converted into estrogen and testosterone. So I do think that it's a viable treatment, however, not as efficacious as the the estriol cream. The SERM ospemifene, can be used in patients who suffer mainly from dyspareunia, however, shows very little efficacy, and I don't think is a very good treatment. I think that we should, as clinicians, shift back to estrogen cream. The newer and kind of more cutting edge therapy is laser treatment. So this is similar to if you were to go in and get laser treatment on your face for your wrinkles or anything like that, right? It's the same idea. There's two different types of vaginal lasers that are in the process of being approved. So one is ablative CO2 therapy. So basically what this does is it takes CO2 and creates a gaseous medium that introduces microtrauma to the epithelium and to the collagen within the vaginal canal. What this does is basically cause trauma that then induces healing, right? So we see a contraction of the collagen fibers and degradation, and then replacement with new collagen, as well as a rapid reconstitution of epithelium. The other type of laser that is offered is an Erbium Yag Laser. The primary difference between the two is that the ablative CO2 it does cause tissue trauma, whereas the Erbium Yag Laser is not ablative. So, and it's a little bit more specific. So, if you're in the surgical world, I like to think of it as kind of your Metzenbaum scissors versus your Mayo scissors, right? One is a lot smaller, a lot more specific, and one is kind of bigger and meant for more area. So these two are being offered by urogynecologists and OBGYNs, and I think we'll see a lot more come out about the efficacy of these treatments. Another treatment that we see, and one, again, that I'm going to relate back to kind of the cosmetic industry, because we see it all the time, is hyaluronic acid. So we see, a lot of cosmetic companies advertise that you should use hyaluronic acid on your face to help with collagen reproduction and kind of collagen maintenance within your tissues. And, vaginal hyaluronic acid is the same. So in a multi-center randomized controlled trial that evaluated hyaluronic acid gel versus estriol vaginal cream, we saw that of the 144 menopausal women who were randomized 1-to-1 into this trial, we saw that there was a non-inferiority associated with the hyaluronic acid. So it was equivalent in improving symptoms overall of GSM. Where I think they divulged, and I do think that this is an important point, is that the estriol group did see kind of that restoration of the normal vaginal canal and the normal microbiome. So we saw pH go down, we saw lactobacilli counts rise with estriol cream, whereas the hyaluronic acid just kind of targeted, I think, the symptomatic sides of GSM. But I do think that this study and hyaluronic acid really is a viable option to offer patients, especially ones who either they have a contraindication to estriol cream and hormone replacement, or they just don't feel it, right? They don't want to take any sort of hormone. The hyaluronic acid, I think, is a great place to start and a viable treatment that I'm sure we'll see become more mainstream in the future. So that was a very fast, very 10,000-foot view of GSM and its treatments. So let's shift gears a little bit from the medical side of things, and let's have a discussion about it from a psychological and kind of a societal standpoint. GSM is underreported, and I think what happens here is a lot of women feel that, and women that are now going through menopause, so that generation, has this mindset that symptoms associated with GSM are just a natural part of aging, that this is kind of just their new norm. And that doesn't have to be. And I think, in the OBGYN field, we're really advocating for patients to speak up and for providers to provide that medium for them to speak up, because this can be an embarrassing topic, right? It's embarrassing to talk to your clinician about. It's embarrassing to address with your partner. And I think it's just important to really focus in that this doesn't have to be the new norm for a patient. They can still enjoy these other parts of their life and still, feel desirable and have a sex life that is enjoyable post-menopause. So in a study published in the 2020 November issue of Menopause, it evaluated how to improve the identification of GSM symptoms. So the goal was to evaluate whether rates of GSM diagnosis increased when every patient that was kind of in that age group that I talked about, so greater than 45 to like 52, was offered a DIVA questionnaire, whether they were presenting with a chief complaint associated with GSM, or if they were just there for their annual wellness visit. Would we see an increase in GSM diagnoses if we offered them the chance to report some of these symptoms? And what we found was, yes, 37% versus 9.7%, a very statistically significant difference between those who completed the questionnaire and those that did not. I thought what was very interesting about this study was that a lot of these patients that reported it and were diagnosed with GSM came from them filling out a DIVA questionnaire at their annual wellness visit. So not anything related to a problem they were having, just given the opportunity to talk about these issues, they were able to identify it and offer treatment. So kind of continuing this, over 50% of postmenopausal women suffer from GSM. And I think, when I was talking this over and talking through this presentation with my preceptor at UConn, one thing that I thought was very interesting was all women go through menopause and reach that kind of relative hypoestrogenic state. I think a source and a new study, a good topic for study would be, why do some women, apparently, according to our data, half of women have these exaggerated symptoms that are associated with a GSM diagnosis, as opposed to just, normal menopausal state? And the answer is, we don't know right now. We don't know why some women just are really hit hard by these symptoms and that loss of estrogen, and why they require treatment. If I were to hypothesize anything, I would guess that a lot of the women who are diagnosed with GSM have histories associated with being very sensitive to any sort of hormonal therapy. And it just could be, their genetic makeup makes them more apt to this diagnosis. As I talked about, many women accept GSM symptoms as a natural part of menopause and aging, but it doesn't have to be. If we offer them that DIVA questionnaire, we offer them the chance to talk about these symptoms with their provider, I think that we can see a lot of fruitful treatment of these patients. I think it's important to address and screen for concerns during visits and bring exposure to treatment modalities now that we have them. In relation to the DIVA questionnaire, so although it is comprehensive, and I think it does a very good job of touching on the multiple areas of life that GSM can affect, it does tend to focus on very heteronormative penetrative sex. It is not very inclusive when it comes to questions regarding alternate forms of sex or regarding different sexual orientations. Or I know something that I talked about extensively with my preceptors and kind of colleagues was that you ask a woman who maybe is postmenopausal in her 60s, does she have pain with sex? And she says no. Well, that would be kind of an exclusion, right, of GSM at that point, because a symptom of GSM is dyspareunia. But you need to kind of further that question because maybe she isn't having any sex, or she isn't engaging in sexual practices due to the GSM. So I think there's a little bit too big of a focus on, is there pain, is there not, associated with this specific activity. I think the DIVA questionnaire can be expanded to be a little bit more inclusive of alternate sexual practices, and to address, the inclusivity aspect of this. Obviously, menopause and GSM, I don't think differs among anybody of a different sexual orientation or different sex practices. So it's important to offer those patients the chance to seek treatment, as well as those in kind of more heteronormative relationships. As far as my presentation, that does it for me. I know that was a very quick overview of a topic that I'm guessing most of us kind of have a little bit of an idea of, but I hope that it shed a little bit of light on how to approach this if you ever do see a patient that's suffering from this, and gave you a little bit of an idea of how to approach it from an OBGYN perspective. So if there's any questions, I would be happy to answer.
Thank you so much, student Dr. Karlinger-Gladney. That was a great presentation. Like he just said, if anybody has any questions, feel free to raise your hand with the Zoom function, or just go ahead and unmute and go for it. Dr. Wolf?
I'll raise my hand just because that's my nature, I guess. So thanks, I enjoyed your talk a lot. I had two questions, actually. Actually, I can stretch that out to three questions, I think, pretty easily. So question number one has to do with, to what extent do people try to take oral contraceptives beyond menopause as a means of trying to stave off some of those problems?
I think that, that's a great question, Dr. Wolf. And I think that kind of goes back to a lot of patients, once they reach that age, they either obviously they don't feel like they need to take them anymore for the contraceptive purpose of them. Also, I think there's a little bit of a concern there from patients and from providers, to be honest, about continuing that estrogen exposure beyond menopause and having that extensive estrogen component. Obviously, with combined oral contraceptives, we have the protective progesterone component, but I think there is just a little bit of a worry there of continuing to expose patients to hormonal therapy. And so that's where we try to kind of, I think, switch to that localized estrogen as opposed to systemic treatment.
So with the prolonged, what particularly is the concern there? Because of course we teach that before menopause you're protected against cardiovascular problems. Now, of course, there's increased risk for thrombosis and things like that, but what specifically are the concerns?
That's a great question. I mean, I know that, we do, as you talked about, estrogen does, even though we do have the progesterone component to it, estrogen does, increase that risk of DVT and kind of that hypercoagulable state. So I would venture a guess to say that that's maybe why. I would have to look into that a little more. I'm guessing you might have a little bit more of an idea than I do.
Actually, I didn't know. I only ask questions when I haven't got a clue.
Okay.
Haven't got a clue.
I do think that that's a valid question, because and it's one that I kind of thought of myself as well. It's like, okay, we say that, well, just from a logical standpoint, you're missing this estrogen. Why don't we just replace the estrogen, kind of like we do in a premenopausal state? And I don't know the specifics of maybe why that would be contraindicated, other than just either patient apprehension, or like I said, just that increased risk of prolonged exposure.
Yeah, Dr. Staudinger said, cancer, so like breast cancer or stuff like that over time. So yeah, there certainly would be some concerns there. The next question that I had to do with, the prolapse, the cystoceles, the rectoceles, and stuff like that. So is there an ability to actually offset that? And I'll further betray my ignorance with, to what extent are pessaries and other things actually used these days?
Yeah, so pessaries are, I think, for for prolapse specific patients, pessaries are still offered as a form of treatment, especially for patients who maybe have contraindications to surgery, still very much used. I think that, depending on the degree of prolapse, so we always do a POPQ questionnaire or a POPQ evaluation to see how extensive that prolapse is. I have seen, at least at UConn, if the prolapse is not, stage 3 or above, or even stage 2, I guess I would venture to say, that vaginal estrogen cream treatment can be used. I don't think that it necessarily reverses any of the prolapse, but in a lot of women suffer from prolapse, but they don't present with symptoms, so they're asymptomatic and just never have it addressed because it's not causing them issues. The main treatment for that still is surgery, so any sort of suspension and fixation, so colporrhaphy. But I do think that the estrogen treatment can help with that. I've seen it a little more with the incontinence side of things. So if they're suffering from stress urinary incontinence due to weakness of that urethral tissue, that's where the estrogen cream really, I think, was used a little more compared to the prolapse.
Okay, I've got another question, but Dr. Talley has one, so I will yield the floor.
I was just thinking, and I came in very late, and I apologize for that, but I was working with a student. And one of my questions is, how is this used for transgender females?
Yeah, so an area that I need to study more, Dr. Talley, absolutely. I didn't see any patients that were identifying as trans female. If I had to venture a guess, I would say that depends on the extent of their anatomy. Transition. So so if they've had sexual reassignment surgery, I would think that would kind of be the tipping point there as to whether or not it would be used. A lot of transgender females obviously go on hormonal therapy and testosterone suppressants and of the sort. So they would be a good question. I think that we know that females are definitely, almost exclusively suffer from things like prolapse and like stress urinary incontinence and GSM symptoms because they go through menopause. So even transgender females don't necessarily go through menopause. So I don't know, so I don't know that it would be as applicable there. But it's, as that becomes, I think, more and more a part of our lives in the medical community, it would be a great idea to explore these treatment modalities for our transgender population as well.
Thank you.
Okay. Dr. Wolf, I think you had one more question.
Sure. I was curious. The other thing that I'm aware, I've encountered 2 OBGYN docs that are big believers in platelet-rich plasma as a treatment for women with sexual problems. Are you familiar with that?
I am not familiar with that. PRP has a lot of, it seems like it's becoming very multimodal. I saw it used a lot in my orthopedics rotation. So I haven't heard about it in terms of OBGYN, but that would be a great thing to explore. I mean, I would guess the thought process there is bring, more nutrients, bring more everything to the tissue to help it, rebuild and at least maintain. I don't know, however, just thinking about it, I don't know how that would affect the hormonal component of GSM. But I would say maybe from a nutritional standpoint, because, as I kind of talked about some of those anatomic changes, that tissue does become less perfused. It becomes friable. So providing maybe that re-enriched platelets to the area could be used. But it was definitely an area that I would be interested in exploring.
I meant to mention too, if you have a question and want to type it in the chat, feel free to do that. You do have one question in the chat. I'll read it so that it's
please
on the recording. this was talking about your previous question by Dr. Talley. It said, and conversely, I would imagine trans men and non-binary people experience menopause if they keep their ovaries too. Is there work being done to update DIVA to make it more inclusive? Thank you for the discussion.
Yeah, I 100% agree. And, I think Ms. Talley's question, yeah, that would have been good for me to address is the opposite side of that. So, transgender females or trans females, transitioning to anatomically female, maybe not as much, but trans men, completely different story. So that it is a great question. And that's the point. I think, there was let me see here. There is it's right here. Improving that my number 2 here was really where I got a lot of the information about how to improve DIVA, because it is a relatively new questionnaire. And I think just the fact that there's a research paper on how to improve it already, there is work being done to be more inclusive of that. And we see that, in the clinic a lot too, is especially relating to OBGYN field, is we ask things that are important for diagnosis. So as I talked about in the DIVA questionnaire, it says, do you have pain with vaginal sex? And that's an important part of GSM diagnosis. However, there's a lot of forms of sexuality that can still be affected by GSM. So yes, I think there is work being done to improve questionnaires to be more inclusive of all types of sexual orientation and identification. I'm not, aware of very specific ones, but I think that, this article was really great in identifying, I think, some of the areas where we do need to improve it. I think we need to, overall in medicine, need to improve our inclusivity a little bit, but specific to this issue, I think that there's definitely work being done.
Thank you so much again, student Dr. Karlinger-Gladney.
Of course.
Great presentation. And thank you everybody for being here on your Friday afternoon.
Thank you, Tanner.
Thank you guys.